Why is polypharmacy a problem? For the patient, it's believed that herbal products are viewed as natural and safe, so taking more is not actually an issue, or having multiple products is not an issue. Vitamins are not viewed as medications. Patients are afraid to stop taking medications once they've started. Patients or their family or their caregiver insist on staying on a specific medication. A patient has multiple providers at different institutions, and patients don't include over-the-counter meds when they're telling us what medications they're taking. For the prescriber, they may be aggressive in their treatments where they're not taking what matters to the patient into consideration. Guidelines for starting medications are established, but there's not a guideline for when to stop a medication. The patient may be new to us as providers, so we're not familiar with what they're taking, and they may not have brought in a list of their medications. Their unclear dosing duration. The patient may not even understand what the dosing intervals are either. And multiple providers that may be prescribing different medications may be unaware of each other and not communicating or coordinating the patient's care. Why is polypharmacy a growing concern? A population is aging. Our population that we are referring to are older adults. And as life expectancy increases, so does the number of individuals managing multiple chronic illnesses. Increase in chronic diseases, which means conditions such as hypertension, diabetes, and depression often require long-term pharmacological or medication therapy. Fragmented healthcare system. Patients seeing multiple specialists may receive prescriptions from multiple providers without coordination between these providers. And overprescribing practices. In some cases, healthcare providers continue medications indefinitely without reassessment.
The aging population of the United States is growing rapidly and expected significantly to impact healthcare systems. In the United States, the population age 65 and plus is projected to increase from 12.4 in 2000 to 19.6 by 2030. Currently, about 14% of U.S. population patients, adults 65 and older. But at the same time, they purchase about 33% of all prescription medications. As we know, prescription medication use increases with age, and studies showed that people age 18 to 44 purchase about 48% of all the medications, while people who are 65 and older, about 89% of people are taking at least one medication. It's projected that by 2040, all the adults will be about 25% of all populations. At the same time, they will be purchasing about 50% of all prescription medication. As with advances in healthcare and technology, life expectancy in the United States has increased, so is the prevalence of chronic medical conditions. As a result, adults 65 and older prescribe a high proportion of medications and related in relation to their percentage in the U.S. population. However, with increased medication use comes increase in the risk. It's estimated that about 10 to 20% of hospital admissions of older adults are actually linked to different types of adverse drug reactions caused specifically by polypharmacy. We also know that the financial burden of polypharmacy is really significant, with medication-related mortalities and cost more than $500 billion every single year. It's very important to understand the rational versus inappropriate polypharmacy. Rational polypharmacy refers to the use of proper medications to manage patients' complex conditions. For example, patients may have different disease states such as diabetes and hypertension and cardiovascular risk. At the same time, inappropriate polypharmacy refers to unnecessary or harmful use of medications without clear indication. It can be prescribing medication just to manage side effects that patients may have.
This diagram shows what appropriate polypharmacy may look like. So at the center, as I said, based on the diagram that shows the goal of our care, is what matters to the patient. Most important is what matters to the patient and or their caregivers. So they agree on a plan of care. We discuss it with them, and they are knowledgeable about what we're trying to inform them about, and they agree on the plan of care. right medicine at the right time, de-prescribing unnecessary medications, so what they're taking is effective and still working for them, and that also decreases the cost and again decreases the possible incident of polypharmacy, so that they end up having a more successful and enjoyable life. Ageism alerts. So these are alerts that we put into our presentation to bring awareness of the person that's observing these presentations of implicit biases that may exist. So efficacy and safety profiles for younger adults versus older adult patients are very different. As a result of that, the physiological and pathological changes of aging. It is ages for medications to be prescribed for older adults similar to that of younger adults, patients or community residents.
So let's talk about pharmacokinetics in older adults. These four processes, absorption, distribution, metabolism, and eliminations, determine how the drug behaves in the body. Absorption, the process by which the medication enters the bloodstream from its sites of administration, such as mouth or skin, and influence the factors by such as drug form, route, food, or stomach pH. Distribution, once in the bloodstream, the drug moves into the tissues, into such as fat, muscle, and brain. And metabolism, the body, mostly liver, breaks down the drug into active forms to prepare for the eliminations. Elimination is a process of removing medication from the body by all routes of elimination. Let's talk about effects of aging on medication absorption and distribution. As individual age, several changes happening in the body, for example, decrease in body fluid water, and older adults have less body water, which reduces the volume of distribution of hydrophilic water-soluble drugs such as aminoglycosides, which results in a higher plasma concentration. Also, we have decrease in lean body mass. With aging, there is a reduction in lean muscle mass and increase in body fat stores. Lipophilic drugs, such as diazepam, tend to accumulate in fat stores, resulting in a longer half-life and prolonged drug action. There is also decrease in plasma protein, albumin, with aging, and highly protein-bound drugs such as phenytoin and warfarin. Lower albumin means more free unbound drug and enhanced risk and enhanced toxicity. Other factors affecting medication metabolism are age and gender, and we know that age-related metabolic slowdown and genetic differences in hormone levels and body composition can influence drug metabolism. Liver congestions from heart failure, for example, also reduces hepatic blood flow and decreasing liver's ability to metabolize drug. Smoking also induces liver enzymes, increasing the metabolism of certain medications. And another important factor is decrease in kidney size and renal blood flow, resulting in decreased renal clearance. Liver is the primary site of medication metabolism. With aging, there are several changes that affect hepatic clearance. Decrease in liver size and mass reduces metabolic capacity. Decrease in hepatic blood flow, up to 50% actually lowers clearance, especially in high excretion drugs. And comorbidities such as heart failure or liver disease can further impair the metabolism. Liver naturally loses some of its ability to metabolize substance, and some of the chronic diseases truly affect the metabolism. For example, such disease states as cirrhosis, alcoholic or non-alcoholic fatty liver, and hepatitis, portal hypertension, and so far, so on. These are the list of the medications that need to be adjusted based on the age and liver function. If we are talking about kidney function, it's extremely important in medication elimination since most of medications are excreted via kidney. Reduced elimination results in medication accumulation and toxicity and accumulating large quantities of medications in the body. As we said, aging and common disease states can impair kidney function. Here is the list of some of the medications that needs to be adjusted with people who have renal dysfunction. And we know that about 14% of people, of patients' population in the United States suffer some forms of chronic kidney disease, and that proportion increases with aging. Let's talk about risk and consequences of polypharmacy. There are a few very important ones. One of them is adverse medication reaction and drug interactions. We know that there is, with polypharmacy, there is an increased risk of reactions. Studies suggest that patients taking 5 or more medications have an increase in the ADRs up to 50%, while people who take 7 and more medications, the risk jumps to 82%. And there is also higher probability of drug interactions, for example, warfarin and NSAIDs. There is an increase in gastrointestinal bleeding. Patients on multiple medications also struggle with adherence due to the complex drug regimens, pill burdens, as well as the side effects. Non-drug adherence can result in disease progression, increased hospitalization, as well as poor health outcomes. And studies also show that up to 50% of patients with chronic disease do not take their medication as prescribed, resulting in annual cost of medication non-adherence in US exceeding $300 billion. Next risk and consequences is cognitive impairments and falls in older adults. Many medications commonly prescribed in older adults can impair cognitive function. Drugs with the central nervous system effects, such as diazepam, opioids, or antihistamines, are linked to cognitive decline and confusion, as well as increased risk of fall in elderly. And that leads to the falls and fracture. And polypharmacy is associated with a 21 to 50% increased risk in fall. Use of sedatives or anticholinergic medication doubles the risk of hip fractures. Next risk is increased hospitalization and health costs. Studies show that polypharmacy is a major driver of emergency department visits and hospital admissions. 10 to 30% of all hospital admissions in older adults are actually directly linked to ADRs caused by inappropriate polypharmacy. And again, financial burden is huge. Annual costs of preventable medication-related hospitalizations exceed $177 billion. Prescribing cascades is a huge problem. A new medication is prescribed to treat side effects of another medication that simply can't be treated and managed properly. For example, a patient is taking calcium channel blocker and they develop edema. As a result, patient is prescribed diuretics, which later causes dehydration and kidney dysfunction. And another risk and consequence is functional decline and reduced quality of life. Polypharmacy really contributes to fatigue, dizziness, confusion, and mental weakness and dependence in elderly patients. And elderly patients on multiple medications report lower health-related quality of life compared to those on fewer medications.
This is an example of a prescribing cascade that Dr. Roitman just defined for us. As I said, one medication is prescribed, causes adverse side effect, and the provider may not be aware or is aware, but prescribes another medication to treat the side effects of the first medication, and on and on. So this is the diagram defining a prescribing cascade. So adverse medication effects of polypharmacy. Polypharmacy and need and the use of multiple medications are associated with higher healthcare costs, as we stated before. Increased risk for an actual medication to medication and medication to illness interactions is also another consequence. Development of worsening multiple geriatric syndromes such as dizziness, falls, and fractures. However, underprescribing medication is not the answer to overprescribing, and necessary treatment is also a concern. So we should never underprescribe because of fear of causing an adverse medication effect. So brainstorm. Polypharmacy is one of the 4 M's, which is the framework of our practice and our clinic. So the question is, does polypharmacy in fact impact the other 3 M's? And the answer is yes, it does. So being overprescribed medication, causing adverse medication effect could affect a person's mentation, their quality of life, their ability to take care of themselves independently, living by themselves independently, and their mobility, and again, it lead to the risk of increased falls and fractures.